How do you treat acute pancreatitis? After you assess severity, when do you send that patient to the ICU? How do you begin the fluid resuscitation? What about pain control, monitoring? When do you start a diet? Antibiotics? When do you do a lap chole? These are all incredibly important questions to know and to be able to answer if you have that patient with either mild or severe acute pancreatitis. Let's get it on. Welcome back to Citizen Surgeon. My name's Dr. Eric Pearson. I'm a pediatric surgeon, and I'm here to scale surgical education. Today, we're talking about acute pancreatitis. We've already gone through the video on causes. We've done a video on how to diagnose acute pancreatitis. We've done another video on how to assess severity, and today we're talking about treatment. We're going to go through all of the important questions that you need to be able to answer either on your exams or if you have that patient on the ward or in the ICU or that consult with acute pancreatitis. Now, remember, we divided this up into two different types of pancreatitis. We have interstitial edematous pancreatitis and we have necrotizing pancreatitis, and it's important to know those definitions. We also learned how to assess severity. So we went through mild acute pancreatitis. That's that patient with no organ failure and no complications. And then we have moderate severe acute pancreatitis and severe acute pancreatitis. So make sure you know those definitions. And when you do, you can get confidently into this subject matter we're going to be talking about today. So let's say you have that 50-year-old patient that's down in the ER and you've made the diagnosis of acute pancreatitis and you want to know, does this patient need to be admitted to the floor or to the ICU? Here are some criteria. So take a look at all of these and you can see that based on the diagnosis, so if it's severe acute pancreatitis, that patient should go to the ICU, or all of these other parameters. So we got to look at their heart rate, their respiratory rate, their mean arterial blood pressure. We want to look at laboratory parameters. So are they hyponatremic? Are they hypokalemic? Do they have hypoxemia? Are they acidotic? Are they hyperglycemic or hypercalcemic? Do they have anuria or mental status changes? If the answer to these questions is yes, then that patient needs more intensive monitoring in a critical care setting. So that's like the first big question that we need to answer when we're beginning to treat this patient with acute pancreatitis. Now, as we go on, I don't want you to think that these are in order of importance, but this first one is critically important, and that is IV fluid resuscitation. So, how do we resuscitate patients with acute pancreatitis? Now, when I was a resident, we used to resuscitate patients very aggressively. Multiple liters of fluid on the initial evaluation, followed by significant maintenance fluids over the course of that first 24 to 48 hours. Now, research has come out that has told us that this aggressive fluid strategy may lead to fluid overload and poor outcomes for our patients. So I'm presenting this patient right here. This is just one of several that looked at having aggressive fluid resuscitation versus limited fluid resuscitation. All right. And I'm going to tell you what fluid in a minute. But if we look at the actual volume, first we want to see, is this patient hypovolemic? Well, how are we going to determine if a patient's hypovolemic? Well, let's look at that physical exam. So let's say we're doing our general inspection. So color, hydration, alertness, nutrition, disability, looking at the limbs, external support, respiratory distress. If we have a patient that has dry mucous membranes, they have mental status changes, they have pruned skin, those are just a couple of general observations. Then if we see perhaps that patient's tachycardic, now maybe they're hypotensive, they have hypovolemia due to this pancreatitis, they've been vomiting, not taking in enough fluid over the last several hours or days, okay? So if that patient's hypovolemic, then we want to start out with a 10 ml per kilo bolus. Now, That might not sound like a lot, but if you have a 70-kilo patient, that's going to be 700 milliliters of fluid as a bolus. And then we start our maintenance fluid. Now, what's the rate of that maintenance fluid? Well, the rate of that is at 1.5 mils per kilo per hour. Now, of course, if we're looking at a patient and they need more fluid, they're in hypovolemic shock or they're anuric, then we may need to give them an additional bolus. But this is a great starting point. Now, why don't we want to aggressively fluid resuscitate that patient? Well, a few videos ago, I put out a video on abdominal compartment syndrome. Now, this is just one complication of fluid overload. But if we aggressively fluid resuscitate and we give multiple liters of fluid, you can see one of the criteria at 48 hours in Ranson's criteria is fluid sequestration. So over 6 liters of fluid, you can see that right here. And if we are giving a ton of fluid, we're going to risk that secondary abdominal compartment syndrome because the fascia that is surrounding the abdominal cavity can only stretch so far. And then once it's limited its ability to stretch or it's limited its ability to distend, then the pressure in the abdomen is going to start to go up and we're going to get abdominal compartment syndrome. Now, that's not the only complication of fluid overload. We can put our patient to heart failure. We can be in respiratory failure. So we want to be very careful when we are doing fluid resuscitation. And there's now good literature to suggest that limited fluid resuscitation can have very good outcomes in that patient with acute pancreatitis. Now, what fluid do we want to use? Initially, normal saline is a great fluid to use for acute pancreatitis and resuscitation. Now, we can also use lactated ringers, but we have to be mindful that lactated ringers is a composition of a number of different electrolytes. So we have sodium, we have potassium, we have chloride, we have calcium. So if we have that patient that is hyperkalemic or hypercalcemic, we have to be very cautious with using high volumes of lactated ringers. Okay, so normal saline is a great fluid to start with this fluid resuscitation. And secondly, there is data to show that resuscitation with lactated ringers increases the risk of systemic inflammatory response syndrome. So another reason why normal saline is a good fluid to use. Now, if that patient is hypernatremic, then perhaps you may need to alter this. But I'm talking about the general patient. Resuscitating with normal saline can be a nice, safe fluid that can improve your outcomes. Now, I've convinced you the amount of fluid, the maintenance rate, the type of fluid. Well, how long do we do this? All right? We don't do it forever, okay? We do it based on goal-directed therapy. So what is goal-directed therapy? Goal-directed therapy just means that we are going to treat until particular goals are reached. So for example, if we're monitoring central venous pressure, we want to resuscitate and continue maintenance fluid until we have a central venous pressure of 8 to 12. We want our goal mean arterial pressure to be 65 to 90 millimeters mercury. Typically, we're not using Swan-Ganz catheters anymore, and so you may not be measuring our central venous oxygen tension, but we want our heart rate to be less than 120. We want our urine output to be 0.5 to 1 mils per kilo per hour. We want our mental status changes to be reversed. We want that patient clear. And we're expecting our hematocrit to drop to a range between 35 and 44%. And that is that hemodilution that's going to occur as we're resuscitating our patient. So those are some goals that we can shoot for if we're resuscitating that patient that's hypovolemic with acute severe pancreatitis or other forms of hypovolemic shock or distributive shock like septic shock. Okay, how long is this going to take? Typically 24 to 48 hours. So that patient needs to be monitored very closely. If we are giving large volumes, then we have to be cognizant of those other complications with large volume resuscitation like heart failure, like respiratory failure, like abdominal compartment syndrome. So now let's move on to pain control. How do we control pain in somebody with acute severe pancreatitis? In someone with severe acute pancreatitis, they have fairly severe abdominal pain. And we can begin that treatment with Tylenol, okay, so acetaminophen. That's going to decrease inflammation. It's also going to provide excellent pain relief. We can use NSAIDs as long as we don't have acute renal injury, and that can be in the form of Toradol. We could also use opioids if we need to for breakthrough pain. And then, of course, there's some good data on regional pain control, even epidural catheters for pain control in acute severe pancreatitis. So there are a lot of different options when it comes to pain control, but in that very first video that I did on the metabolic responsive injury, when we're talking about pain, hypovolemia, and circulating stuff, pain has a lot of consequences. So increased epinephrine, norepinephrine, cortisol release, all of those associated inflammatory hormones and cytokines. So we want to control the pain in our patient, not only for their comfort, but to limit that systemic inflammatory response. And if we have that patient in the ICU, how are we going to monitor them? First is vital signs. So we have to consistently be monitoring their temperature, their heart rate, their blood pressure, their respiratory rate. All of those need to be measured on a consistent basis. We want to measure the urine output. That's going to be one of the best indicators of our volume status and shooting for that goal of 0.5 ml to 1 ml per kilo per hour. We're going to be measuring our electrolytes. So if we are resuscitating this patient, if we had an abnormal electrolyte panel, we're going to want to see how those electrolytes are changing. Perhaps after 6 hours or 12 hours, we need to repeat that basic metabolic profile so that we know how our electrolytes are changing. All right. And then finally, we want to consistently measure our serum glucose. Make sure we're not hyper or hypoglycemic. As we know in the critically injured patient, those hypoglycemia can lead to adverse outcomes. Now we get to nutrition. So nutrition is incredibly important in that patient with acute pancreatitis. And the big question on your mind is, okay, well, when do you start? Well, the whole idea of pancreatic rest is gone. When I started my training, we used to rest the pancreas. So we would put in a nasogastric tube to pull out any secretions that were going to go past and stimulate the pancreas. We would do post-pancreatic jejunal feeds with an enteric tube just to rest that pancreas. But the literature now shows us that we don't need to do that. In fact, if we have a patient that does not have an ileus, doesn't have signs of obstruction, and can tolerate a diet, then we can start a low-fat, low-residue diet almost immediately. Okay, so if say you have somebody who you're actively fluid resuscitating for hypovolemic shock, you're not going to start a diet in that patient. But perhaps after they're resuscitated, after 24 to 48 hours, we're going to start our nutrition. Okay, and so if they don't have an ileus, then you could try starting a low-fat, low-residue diet. Now, what does that mean, low-fat? Well, low-fat in mild acute pancreatitis would typically be 30 to 50 grams of fat per day. If we're looking at severe acute pancreatitis, we may want to limit that even further to 20 to 30 grams of fat per day to limit that stimulation of the pancreas. Well, what is low residue? In the GI tract, we use the word residue to refer to anything that is undigested, and that typically refers to fiber. So we want to have a low-fat, low-fiber diet. Okay, so that's like, if you think about it, that's like a kid's favorite type of food. Okay, so white pasta, white bread, white rice, stuff without fiber in it. Okay, so we can do that if that patient doesn't have an ileus. All right, well, let's say they do have an ileus. Well, then we may have to give total parenteral nutrition. But before we get that far, let's just say that their gut's working, but they are intubated and they can't eat. Do we do enteral feeds or do we do parenteral feeds? Well, the answer is that we want to do enteral feeds. And that can be either nasogastric or nasojejunal feeds with a small bore tube. And we want to start something that's low fat and high protein, something like Peptamen AF. Okay, and we can start that if we have that patient that we can't feed orally, but they would be able to tolerate enteral intake. So when is TPN indicated? So TPN is indicated in that patient that has obstructive symptoms or an ileus, okay, abdominal distension, not going to tolerate anything in the intestine, or if we haven't been able to advance to goal feeds in an appropriate amount of time, so 5 to 7 days. Now, if you need a good refresher on total parenteral nutrition, I have a bunch of videos that I published right when I got started that I think are great videos on not only nutritional assessment, but how we can think about TPN as fluid and energy, and even a video on how we could create a batch of TPN. Okay, and I think that's a great review that any medical student interested in surgery or medicine for that matter, and especially any surgical resident, needs to be able to do. Okay, well, let's get into another important topic, and that is antibiotics. Now, if we have mild acute pancreatitis or severe acute pancreatitis, and we think that this is interstitial edematous pancreatitis or even necrotizing pancreatitis, we don't need to prophylactically give antibiotics, okay? We used to do that, but we now know that we don't need to prophylactically give antibiotics. Now, if we think that the patient may have an infection, so they're having a fever, or on that CT scan, we see some air within the pancreas, or other markers are changing, so for example, an elevated calcitonin, we may want to start empiric antibiotics. But if that patient deteriorates, we need to investigate that. And how do we do that? We do that with cross-sectional imaging, and a CT scan is an excellent place to start to get nice axial images so we can look at that pancreas and see, do we have areas of necrosis? Do we have complications of pancreatitis? We're going to talk about those in a little bit, okay? Or do we have infected pancreatic necrosis? Now, thinking about those complications, what could those complications be? Well, number one, you could have acute peripancreatic fluid collection. If it was later in the course, so 4 to 6 weeks down the road, we could have a pseudocyst. Early in the course, we could also have an acute necrotic collection, or similarly later in the course, we could have a walled off pancreatic necrosis. So what is the greatest threat to life in a patient, let's take away comorbidities, but in a patient with severe acute pancreatitis? The greatest threat to life is if we have infected necrosis. Now, infected necrosis can occur in up to 1/3 of patients who have pancreatic necrosis in severe acute pancreatitis, okay? And when we look at it, we need to suspect infected pancreatic necrosis if we have a patient that clinically deteriorates. If this occurs late in the clinical course, and if we do have infected pancreatic necrosis, it is typically monomicrobial, something like E. coli, Klebsiella, or Pseudomonas, and even Enterococcus. So what are the risk factors of getting infected pancreatic necrosis? Well, the risk factors include an older age, and I'm going to direct you to this paper. I'll put a link to it in the description below, but older age, having gallstones as the etiology. Also, if we have greater than 50% of the pancreas is necrotic on cross-sectional imaging, and if that patient needed invasive mechanical ventilation. So these are some of the risk factors for infected pancreatic necrosis. Now, what is the treatment for this? First is to initiate antibiotic treatment with an antibiotic that can penetrate the pancreas, and those would be your carbapenems. So meropenem, ertapenem. Carbapenems are the antibiotic that will penetrate the pancreas and begin to treat that infection. We want to monitor very closely in an intensive care unit to monitor for clinical deterioration. And if that patient clinically deteriorates on antibiotics and being resuscitated, then they may need a necrosectomy, and that may be done with a percutaneous drain from radiology, or it could be done endoscopically through the stomach, or perhaps open or even a laparoscopic retroperitoneal necrosectomy. I'm not going to get into the details of that. If you'd like me to do a video on that, definitely put that in the comments below and we can get into more the technical aspects of necrosectomy. Now, what if we have sterile necrosis, so no infection? We want to discontinue any antibiotics and we want to do non-operative treatment for 6 to 8 weeks. And so if we have sterile necrosis, what are the indications for necrosectomy or intervention? Well, if we have obstructive symptoms, if we have persistent symptoms after 8 weeks, or if we have something like disconnected duct syndrome, where because of the necrosis, that main pancreatic duct is disrupted. If we have any of those, then we may need to do some type of intervention. Well, what are the important indications for a pancreatic necrosectomy? Well, number 1 is infected pancreatic necrosis. Number 2 is organ failure. And number 3 is prolonged pain. So those are the most common indications for an intervention for pancreatic necrosis. Now, what are some other complications that are possible with severe acute pancreatitis? Well, we can get splanchnic vein thrombosis. We can get a pseudoaneurysm. We can get abdominal compartment syndrome, diabetes, and of course, exacerbation of the disease or deterioration in our patient. And so now I want to take the most common cause of severe acute pancreatitis, gallstones, and let's go through how we would treat the gallbladder when it comes to somebody with severe acute pancreatitis. So when do we take the gallbladder out? Well, if we have mild acute pancreatitis caused by gallstones or even sludge, we're going to see that in a minute, then we want to take that gallbladder out with a laparoscopic cholecystectomy or a robotic cholecystectomy within that hospital admission and within 7 days. That would be an early cholecystectomy, and that's been shown to have better outcomes than a delayed cholecystectomy because of the risk of recurrent pancreatitis. Now, what about severe acute pancreatitis? Well, in severe acute pancreatitis, early cholecystectomy is actually shown to have increased morbidity and mortality compared to delayed cholecystectomy. So when do we do a cholecystectomy here? We do that after inflammation resolves, and that may be 4 to 6 weeks after that severe acute pancreatitis episode. Now, like I said earlier, what if you don't have stones? What if you just have sludge? Well, even if you have sludge, the recommendations are to perform a cholecystectomy if indeed gallstones or sludge are the cause of that acute pancreatitis. Why do we take the gallbladder again? Well, we take the gallbladder out because there's a 25 to 30% chance of having severe acute pancreatitis again if that gallbladder isn't taken out in the next 6 to 18 weeks. And so that's why for mild forms, we want to take that gallbladder out at that index admission or within 7 days. And for severe acute pancreatitis, we want to take that gallbladder out after the inflammation resolves. Okay, so today we went through a ton. Okay, we talked about the treatment of severe acute pancreatitis and mild acute pancreatitis. We talked about when to send that patient to the ICU. All right, so do you remember all of those criteria? You can go back to that. All right, we talked about IV fluid resuscitation. We talked about nutrition. We talked about antibiotics. We talked about infected pancreatic necrosis, that being the greatest threat to life in somebody with acute pancreatitis. And of course, we talked about the indications for intervention or necrosectomy. Okay, we tied it up with talking about when we should perform cholecystectomy. So for mild acute pancreatitis, we want to perform that within 7 days in the index admission. And for severe acute pancreatitis, later on after the inflammation resolves, knowing that we have a 25 to 30% risk of recurrent pancreatitis if that gallbladder is not removed. All right, so as always, I hope you enjoyed this. If you did, give it a like, give it a share, leave a comment below, engage with me. I love answering your questions. I love the clinical stories that you share, whether of a patient you've taken care of, or even for those of you who are not in medicine, but have experienced or have family experiencing these medical problems, sharing those stories with me. I absolutely love that. Stay safe, study hard. I'll see you next time.